All right, good afternoon. My name is Rachel Erickson. I am here with our Sam Houston State University College of Osteopathic Medicine. It is right at 12 noon. We will let some of our attendees get into the room, so we'll get started in just a minute. All right, I see we have a good group coming in. Again, welcome, good afternoon. Today is our November continuing medical education offering here at Sam Houston State University College of Osteopathic Medicine. I am very excited to introduce our speaker, Dr. Kevin Kalinowski. He'll be presenting today on robust narrative feedback for our MSPs. So hopefully we're going to be in for a lot of great information and working with both our faculty and our preceptors. But before we get started, I'd love to introduce our speaker formally. So Dr. Kalinowski joined Sam Houston State University in February 2019 to help launch our College of Osteopathic Medicine here in Conroe, Texas. He serves as our Director of Assessment and Accreditation. His responsibilities include managing processes, data, and workflow for assessments, evaluation, accreditation activities, plus the design and delivery associated with our faculty and our professional development opportunities. Prior to his service here at Sam Houston State University, he served as the Director of Assessment and Program Evaluation and co-director of the Small Interactive Group Sessions case-based curricular component of the DO program at another new osteopathic medical school, the University of Incarnate Word School of Osteopathic Medicine in San Antonio, Texas. Prior to moving back to Texas, he was a psychometrician at the National Board of Osteopathic Medical Examiners in Chicago, where he co-managed the Comprehensive Osteopathic Medical Achievement Test, the COMAT. And in addition, Dr. Kalinowski worked on the COMLEX USA Licensure Examination Series, including the new clinical decision-making item format for Level 3, and was a member of the Portfolio and Expanded Assessment Task Force. So before the NBOME, he worked at UNTHSC in Fort Worth as a Director of Research and at an early reading software company in Dallas, and a high school science teacher and mathematics teacher in North Central Rural Texas. We are very excited for Dr. Kalinowski to present today. We will cover some of our CME claim credit information at the end of our presentation so that I don't take up any more of your time. Dr. Kalinowski, thank you for being here to present, and the floor is yours.
All right, thank you so much. And so yes, my name is Kevin Kalinowski. I'm Director of Assessment, Evaluation, and Accreditation. So I'm that weird one who sees everything and tries to help people make things better. So that's my role here at the COM. First thing we'll do is, whoa, this is very touchy. Just kind of get this out of the way. I have no conflict of interest related to this presentation, and I have no relevant financial relationships with any commercial interest related to the subject or nature of this presentation. So given that, all right, so we'll start off with our learning objectives. So by the end of this session, you should be able to describe the core competencies of an effective narrative evaluation, and you should be able to compose a narrative evaluation that provides some useful information for both students and faculty. And so you'll see down in the corner this little snapshot that I made. And when my boss, the Associate Dean for Educational Affairs, said, hey, Kevin, could you do something on narrative, the narratives in MSPEs? I said, sure. So I literally typed in to Google robust narrative feedback for MSPEs, and lo and behold, out came this AAMC MedEd portal article entitled Preparing Effective Narrative Evaluations for Medical School Performance Evaluation, or MSPE. And I was like, oh my goodness, this is exactly what I need to do. So these two objectives come directly from them. And I just want to full disclosure that I didn't reinvent the wheel. I am basically helping unpack what I think is an amazing article. And in addition, they have a lot of activity guides and ways to help you. Let's say you wanted to do your own fact dev on this, and kind of working together as teams to be better evaluators, especially with the narrative component. So I encourage you to read this, and if you do, you'll see a lot of the same things over again. Okay, so first of all, let's see, click on that. All right, so if you saw me back in the springtime, you would have seen this slide. I covered a few things in my first CME on evaluation, and one was kind of an evaluation in general, like what is it and where is it used in the comm, and so really just very simply, we're just judging something. When we evaluate, and hopefully it's based on a set of standards versus just some kind of off the cuff sort of idea of what you want. And then what I did was I talked about various types of bias. And so there's some obvious biases that come up in the news a lot, but these are more nuanced biases, ones that you would see as preceptors that might, if you're aware of it, you might be able to circumvent. So there were 7. One is the recency or primacy bias, and that's kind of the first impression and you stick with it, or whatever they did on that last couple of days, that's what you focus on, and you kind of forget about the progress that they made from day 1 to those last couple of days in your rotation. So that's one type of bias, and we just wanted, we for each one of these types, we said this is how you overcome it. And a lot of these were take it all in, don't judge on day 1 or the last day, but kind of take in the entire process of that student, with you as the preceptor mentoring them through a process. Second one was halo horns, and that's looking for good and bad aspects or characteristics, and then let that overshadow everything. And that, especially with that first impression, they might be nervous, especially if they're coming into you in, let's say, July, and they're wide-eyed and maybe a bit eager, and suddenly you focus on that one characteristic and let that overshadow. Another one, central tendency, kind of back when I used to give preceptor evaluations to every like paper versions to preceptors, that whole check down the middle and just draw the line straight down, sign it, and you turn it in, and everybody gets the middle. We don't want that, because what we have is every student has strength and opportunities for improvement in various areas, and that's why the evaluation form is more than just pick C all the way down. Leniency bias was the 4th one, and that's just kind of not wanting to rock the boat, kind of knowing that there's an opportunity for an improvement, but not addressing it, and especially kind of maybe because you didn't catch it early enough, and then suddenly you're like, we'll let somebody else deal with that. And eventually it'll catch up to the students, but that's something that we want to just kind of make sure that we embrace everything about the student when they're rotating through with you. The similar to me bias, and I'm so sorry, I'm gonna mute myself just so I can clear my throat for a second. There we go. And that's kind of saying, I went to UT, and so somebody might, if I was a preceptor, rotate through me and realize they're also a Longhorn, and oh my goodness, and we sit there and we talk about the year and move into a different conference, and we're talking about everything but rotating through and all the experiences. So that's similar to me bias, and actually rating them higher because of that. The number 6 was confirmation bias, and that's just finding facts to justify your hunch, kind of like just saying, you know, I knew they were this, and then just checking boxes along the way and kind of using that as evidence without taking in all the wonderful things that person might have done. And finally, the ones that we kind of think about when we think about bias: gender, age, and race. And we talked a little bit about that. So I stress this because this creeps up. All sorts of bias creeps up, and we just want to make sure that we're aware of it so that when we're writing these narrative evaluations, we can try to avoid them. Okay, and then the last thing I talked about was our evaluations here at the COM. And so of all the ones that we talked about in the previous one, today we're only going to focus on one: preceptor evaluation of the student, and that's it. So given that, the preceptor evaluation of the student is given in the 4th week. It is summative. There's a midpoint evaluation that's more formative in nature, and we're just looking at that point for big red flags that we can fix. But here is, you've seen them for 4 weeks. There are 7 ratings, one for each one of the core competencies. So you will have seen those before in your career, and so they are now acutely aware. Every single thing that they did in year 1 and year 2 through session objectives that tied to course objectives, those course objectives tied to one of those 7 as well. So the student should be aware of it. And the scale is exceeding, meeting, or does not meet competency, or unable to assess, because maybe you're an MD and one of the 7 is osteopathic principles and practices, and you're just not in tune with that. You don't understand how to assess whether or not they know the tenets and models, and you just sit unable to assess, and that's fine. Then there's that overall rating down at the bottom: outstanding, good, minimal, unsatisfactory, or unsafe performance. And that's kind of overall performance. And if they get unsatisfactory or unsafe, many people are emailed. And so we go into kind of a triage mode to find out why. Because just like you, we do not want unsafe individuals practicing medicine. So, you know, a lot of that is just trying to figure out what's going on. And when we get either outstanding, good, or unsatisfactory or unsafe, those, we're looking at your comments. So if you were to rate them in anything, the first thing we do is we look at the comments, and we ask you at the end of this evaluation, 2 to 4 sentences. Tell us about their performance. Examples, specific examples are encouraged. And then just a reminder that they are always going to be improving. So as they journey through this lifelong process, they need to know growth opportunities, and they need to be able to see evidence that they did grow, because you'll pass them on to the next rotation, and maybe something will pop up, and they'll be able to read the next preceptor, and they can feel proud about progress, right? And then finally, there's a little statement about it may be quoted verbatim in the dean's letter. So let's talk a little bit about the dean's letters. Back about 6 years ago, AAMC had a task force on MSPEs, and in their template on page 2, they explicitly say clerkship evaluations are the most important section of the MSPE, and they did not try to hide it. These are important, so much so that year 1 and 2 in an MSP is summarized into: they did okay, they didn't have any remediation, or they didn't have any failures, or this is their class rank. It's 1 or 2 sentences, and then literally 4 to 6 pages of the MSPE is focusing on the evaluations. But they didn't tell anybody how to write the narratives. But they did say, do faculty development. So you're here because they explicitly said, we're not going to tell you how to write the narratives, but you should kind of have some framework in which to do it so that you do it effectively. Okay. So what do the students care about? Well, they care about the match. What do the comms care about? They care about the match. Why? Because our accreditors, LCME and COCA, hold us to first-time pass rates on the boards, as well as placements in residency programs. And of course, the students just want to graduate and get out there and start being a doctor, instead of just learning on how to be a doctor. So, I mean, that's their motivation, is the match. But the program director, the residency program director, they want good fit, right? And so they have a lot of evidence that they have to go through in these applications. And so this is 2020 survey. And I believe these were allopathic surveys, this one. They also have an osteopathic one, which is very similar. 650 residency program directors replied, and they said, hey, how important are these aspects of an application? And notice the scores up top, 1 and 3. But guess what? They're all moving to pass fail. So there's no more looking at a score and saying, this person clearly knows the medical knowledge or the clinical the clinical aspect of things like treatment or management or diagnosis, versus this one, because look, their scores are so much higher. No. Starting with our graduates, every pass is a pass, and it doesn't matter if you barely pass or you are off the charts passing. Passing the boards is just passing the boards. So that's going to be critical that other aspects of their application come into play. Why I highlighted letters of recommendation and the MSPEs is because those are the two areas in which a residency program director gains insight on what it's like to work with these students. Everything else is just numbers and kind of a personal statement, and I can sell myself however I want to. But these two are your peers, you and your peers, physicians, working with the students and writing in some kind of, narrative way. It was good to work with them. They met challenges and they overcame it, showing examples of how they will eventually become competent and caring physicians. So that's why these two are so important, especially as the boards all become pass-fail. These are going to wind up being critical to getting into a good residency. Okay, so why do they use these MSPEs? Well, one is any of these data is one, because they have too many applicants for too few slots. We know that, and they want the best fit possible. I highlighted something because even though the MSPs are supposed to be standardized, we as a COM are responsible for what goes into an MSPE. And over again, I hear program directors saying, yeah, but what are they hiding from me? And you, if you've ever done this before, know certain comms you can trust more than other comms because they tend to be more transparent, or they tend to include more information that help you as a program director make a better decision. Right? So they're using this to screen for interviews, and that's why the narratives literally cut and pasted from what you type in the form go into the MSPEs, and other than an obvious typo, we don't want to embarrass anybody. So if there's an obvious typo, we might clean up something like that, but we do not touch these. We have them in a big spreadsheet, and they just get dumped into the MSPEs as is. And a lot of these program directors are using it to screen for red flags. So let's talk about a red flag. A third, fourth year medical student are going out for auditions and interviews. The program director has the MSP and other data in front of them. And one of the worst things that a program director might read is simply showed improvement. This qualifier, even though you know that is a positive attribute, right? They improved. The way it is written, especially without any evidence to back it up, tends to be thought of as a more weaker applicant who did better after 4 weeks. And that's why we're going to spend the next couple of slides talking about why qualifiers are dangerous, because my definition of showing improvement is different from your definition of showing improvement. And the residency program director, without any evidence, will probably see that and read that maybe in a more biased way than if they read, let's say, a statement of evidence. The evidence could be started the rotation where I would expect for a level of training, but improved consistently. Okay, clearly showing improvement. But the problem with evidence is that I don't know where this person started. If this person was on their third surgical rotation, that is a different story than somebody who was just unlucky enough on their first rotation. I mean, literally right after our prep course, and we're saying you're going to have to sign a lease and start rotating. Their first rotation is surgery, core general surgery. And they are wide-eyed without any concept of what it's like to do a rotation with a preceptor, let alone in a surgical context. So the starting points are different, and program directors, now the student might read that and see that they made improvement. But remember, to get into residency, the program director needs to read that and understand what's going on. So an example is so much better. Showed great improvement in that by the end of the rotation, they were able to carry out multiple patients. They were able to carry multiple patients, including the most complex on our service, without difficulty. And that would let me, as somebody evaluating this student, realize that they did show improvement, but the improvement was carrying more load, right? So I can infer from that example that in the beginning, maybe they just couldn't handle the load quite as well, but by the end, they were just doing what I needed them to do and what I expected them to do, and they made that growth over 4 weeks. So that's why those examples are key. Another one that we see is competent. And this is another one of those red flag, especially when it is applied to underrepresented minorities. And in a study that I have in my notes, so when you get this slide deck, you'll actually be able to see it. There was a study out of 2017 that it was, let's see, racial and gender bias in, where is this? No, I don't have the actual, no, I don't actually have where it was. It was pediatrics, I'm almost positive. And it was just one of those words that even though you are talking about competency, when applied to certain groups of people, might come across as a negative trait or a negative characteristic. Now, the evidence definitely is better, did a nice job taking history. So now you're saying what this person actually did. But now when you look at the example, this is a definition of competency. She demonstrated excellent clinical judgment. Now, that goes back to one of those things that they're supposed to be able to do by the time they get into residency, right? Quickly recognize a child's worsening respiratory status while taking the history and notify the team immediately. And I'm thinking, if I read this as an application into a residency program that I was directing, I would look at this and I'd go, dang, that's what I want. I want somebody who's aware, who has good judgment, and is not willing to just take it all on themselves, but actually run it up the chain to people who are competent and able to actually make that clinical decision to help the patient. This is what we're talking about when we're talking about effective narratives. So when that first objective is what is basically these three things: that effective narrative evaluation, comment on performance. And the way we do that is we include both strengths and weaknesses. If we need to include weaknesses, don't be biased there, the leniency bias, but include both if both are observed. Focus on their performance and not some speculation about their future as a physician. And the way you do that is by focusing on examples. And you clearly describe to the program director and to the student what they did specifically that made you evaluate them in one way or the other. And then you're writing not only to the student so the student can improve over time, but you're also writing to their future employer. Okay, so one last one. Let's talk about hard worker. And when I look at hard worker, I think I had a bunch of them here. Good job, interested, punctual, professional. They're just more qualifiers. They're just more tags that do not mean anything when we're talking about this specific human being, this specific student trying to apply for a residency position, right? Evidence is better. Great team member, always helping out with tasks that need to get done. Okay, great. And you've kind of given some evidence, but look at this example. Student took the time to make a phone call to an outside hospital to obtain much needed records for the team. That's initiative. That's more than just being a hard worker. That's taking that initiative. And if think about when you were applying for residencies, these are the sort of things that would set you apart from all the other applicants. Okay, so now I'm writing them down. This is your job now, is you're sitting down at your computer and you're writing these things and you're going, yeah, but what am I actually going to write? You told me I need examples, but how does that play out? Am I just going to pick examples? No, what you're going to do is you're going to pick a framework first. And then you're going to only focus on one or two or maybe even three of those areas within that framework. And then you find the examples to support your decision. All right. So we have some standardized frameworks, and you're probably familiar with at least a couple, if not all of them. The first, ACGME core competencies. And that's going to be well understood by the program director because this is the language in which they speak. This is the language in which you were held accountable to when you were going through your residency. So this is a common language, and so it's well understood and probably something that the students can then tie back to because it's very much also in alignment with the AOA core competencies as well. Rhyme is a modified rhyme. This is more familiar with us in the UME world, right? This is ClinEd. This is the rhyme that's been modified with a P and a plus. We'll talk about these two. That's why I've bolded those two a little bit more in a second. EPAs, this is what they're supposed to know before they get into residency, right? There's 10 of them. And AAMC and ACOM both came out with their lists of 10 EPAs. And the difference is ACOM basically put osteopathic distinctiveness into the AAMCs. So it doesn't matter if you're an MD or DO, professionalism is professionalism. There just might be viewed through a different lens when you look at the DO version of it versus the MD version of it. But these are things that probably, you know, very much you would want to promote as a preceptor mentoring the students. And then finally, KSAs. This is kind of grounded a bit earlier, you know, K through 16 sort of world, but even in our world, UME world, and the GME world, do you have the knowledge, the skills, and the attitudes to get a job done? And so we'll look through all of these and just kind of understand that we can pick any one of these, and that same narrative could be applied to the other three. So it doesn't matter which one you pick. I could probably find evidence in the other three and show you that you're doing the same thing with the same narrative, just through a different lens. So ACGME, starting off with patient care. So this is the primary goal of you know, that compassionate care for healthcare outcomes. So that's a good lens to look at, and you as a preceptor might focus on patient care because that's where they're going to interact a lot with. But then systems-based practice, where they're looking at the bigger picture, they're looking at how the components of healthcare work together towards the solution. This might be something that'll come out in rural and underserved, where maybe some other services need to come into play outside of the clinic in order for the complete healthcare to happen. And a student being aware of those might be something you might want to document. Medical knowledge, obviously, for 2 years, they've been, crammed full of medical knowledge, but they're not opening up the genetics textbook when they're rotating through you, but they have to recall that, and it might be something you identify. Interpersonal and communication skills, those are more softer skills that are we're trying to promote with more exposure to patients and more exposure to healthcare teams so that they're working together towards a common outcome. Professionalism, that's another one. That's not only being ethical, but also being responsible and respecting not only the team, but as well as the patient. And then finally, this last one that often gets overlooked, but you can always capitalize upon this if you see growth: practice-based learning and improvement. This is that reflective component where they're actually looking and improving and trying to get better, and you can capitalize upon that when you see growth opportunities. Okay, and yeah, so that's ACGME. Prime Plus, that's a nice one because each one of these letters has kind of the lens in which we look at an observation, some kind of artifact that we're evaluating. P for professionalism, okay, that is, that motivation, that initiative. It's more than just showing up, looking nice and speaking well. It's kind of the bigger picture of putting on the dare I say, armor of being a physician, trying to, follow in your footsteps as a role model on what it feels like to be a professional leader of a healthcare team. So they'll be looking up to you in that respect. A reporter, gathering information, an interpreter, critical thinking, being probed for a differential and actually coming up with a couple possibilities, and then you guiding them through, but did you consider this? And they're like, oh, of course not, because they're new, right? And they need that guidance from you. Manager, looking for that next logical step, especially when you're asking them, okay, so what should we do next? And them coming up with something that seems reasonable. Education, not only of other people, we don't necessarily want our students going around pretending to be something, but being a helper. Even educating the maybe the patient to, well, did you ask your physician? That simple step of being their advocate, of kind of helping them take ownership of their health, could be part of the educator role, as well as self-education, right? The ability to educate themselves, especially when you challenge them to go back and look that up because clearly you don't remember or you don't know something. And then that opportunities for improvement. So can you see the plus here goes back to problem-based learning and improvement. Those two are synonymous. So any type of improvement, I can choose either one of those, right? So let's look at an example, and I'll just read this out loud. If I was doing this interactively, one of you would be voluntold to do it. And so I'll voluntold myself. Student A was always prepared, having studied patient charts in depth prior to entering the exam room. In one instance, her preparation saved potential disaster when a patient failed to show up for her appointment. Student A realized that the patient had not been given a referral for the evaluation of a mass in her thyroid. Due to her excellent preparation and alarm, we were able to intervene. Wow. I mean, that's fantastic. And now notice, this is one example, and this could be everything in your narrative. You do not need to have an example per day or an example per week. We're talking about that example that sometime within the 4 weeks made you think, wow, this student did something well, and we need to document that for the program directors and for themselves so they can be proud of this accomplishment, right? So if I looked at ACGME and a lot of these, obviously there's patient care, right? Patient care is in there, systems-based practice, that the referral, right? That this is bigger than just what is happening in this office in this moment, and problem-based learning and improvement, you know, just trying to sort through and rationalize what went wrong and trying to make that improvement. But we could also scrap ACGME entirely. We could say, no, that's not what I'm going to use. I'm going to go with Prime Plus. So the P for professionalism, because they were prepared. They were always prepared. That, remember, that was part of professionalism, is coming in prepared, because that's what's expected of them. The interpreter and manager, being proactive in this moment and acting as an advocate for the patient. So, you know, I have a P, an I, and an M in Prime Plus that I could put in there easily. EPA number 3, because they recorded and interpreted diagnostic and screening tests, right? That there was something missing that needed to be taken care of. EPA 13, system failures. You know, there was a failure in the system, it was identified, and supervisors were noted. Fantastic. How about KSAs? The knowledge of working up the thyroid mass, the skills, the ability to assess if testing had been completed, and finally the attitudes, the advocating for the patient and identifying a system failure. So that one example, all 4 of those frameworks could have been utilized. And in each one, we focused on 1, 2, or 3 aspects of the framework with that one example. And so when we ask you to have effective narrative feedback in your preceptor evaluations of the students, this is what we're looking for, that example with the evidence that shows that they are going to be good residents, right? Okay, we got another example. Patient presentations and assessments were thorough, polished, and organized. If I interpreted a presentation to ask a question, he got right back into the flow with ease and incorporated feedback immediately. For example, with a headache patient, he was able to diagnose migraine with aura instead of complicated migraine, immediately internalizing the feedback I had given at the start of the presentation. Given several topics to discuss, always came prepared with well thought out and put together presentations, exceptional team player, unmatched work ethic, superior patient notes, including some that were truly outstanding, including sophisticated localization. He created a neurocritical care template note for future students' use. My goodness, we all need to hire more of these, right? It's a lot of work on your part. You might not be able to put all of those pieces in, but you could have started with, for example, and focused on that. And then maybe that little bit at the end, that little bit of initiative at the end. And if I were to look at this, I would look at patient care, problem-based improvement, that soft skills with interprofessionalism and communication, and finally just flat out professionalism, right? So all of those could be focused. This is a very thick example, but it goes into a lot of aspects. My notes, they created a template for other students and the work ethic and the team players. So there's your professionalism and educator roles of Prime, right? The R, the organized presentation, there's that reporter, right? Because they're acting as a reporter. The management, this differential diagnoses, and interpreter management, they kind of get lumped together, I and M together often because of the differentials, right? I picked EPA 1, history and physical, EPA 2, differential, EPA 6, oral presentation, EPA 7, clinical questions and retrieval of evidence to advance patient care. And then with knowledge, I picked knowledge, the ability to diagnose, skills, research topics, and attitudes, creating that template for others. Does not matter which framework, I still hit on everything. Focus on the examples, have that framework next to you when you write these things up, and it will naturally just form into a narrative that will be effective. We have another example. Example 3, this is student N, was a valuable member of our team and was attentive on rounds, at times knowing details about the patients and their management plans that the interns and senior resident could not remember. She also went beyond the duties of a third year and went out of her way to assist interns with tasks such as tracking down a family member for a patient with dementia who needed a procedure and could not provide consent. Bomb. Oh, I love it. I mean, you just want to wrap your arms around this person and say, this is what we need, right? So patient care and professionalism, clearly. I also had professionalism, reporter manager for Prime Plus, EPA 6, oral presentations, EPA 7, retrieval of evidence to advance patient care, EPA 11, informed consent. Beautiful. The knowledge of patient data, the skills required to obtain informed consent, and finally the attitudes, just being helpful to others. So you could have reworded this and actually work through each one of those and come up with the same example. Example 4, student K is an exceptional individual and an outstanding student, driven by a deep sense of compassion and justice, and recognizing inequities in healthcare delivery, she decided long ago that she would become a physician. So here's some kind of evidence, right, that the preceptor talked to this student to get to know, well, why do you want to be a doctor? And just for whatever reason, this impressed upon this preceptor to jot this down as some kind of context for what they're about to say. This passion was apparent every day during the elective. She sought to understand patient needs beyond their physical ailments. Her patient interviews always included questions regarding living conditions, employment, other social determinants, so she could get a complete picture of any obstacles to care, which is fantastic. This is looking outside of the room into the things that underlie healthcare conditions. Absolutely fantastic. So we see, I mean, across the board, just about everything. Systems-based, the integration of all these components, from epidemiological sort of evidence to what's presenting in the office, improvement, patient care, communication, professionalism. And I'm not even going to go through my other ones, but you could think, doesn't matter, Prime Plus, EPAs or KSAs, they all show up there in various degrees. Okay, so here's one written just to Prime Plus. And the thing about it, when you write to Prime Plus, you typically will start working through all of the letters as you're writing this up. This is a thick one, and it goes well beyond the 2 to 4 sentences, but just try to see if you can see the P, the R, the I, the M, the E, and the plus as we work all the way down. Student G was punctual, helpful to the staff, and respectful to all the patients that she interacted with. There's the P. Her presentations were consistently accurate, organized, and thorough. Reporter. You see what I'm saying? Each letter is being introduced. She rarely left out details, and I was impressed that she was able to provide bedside presentations that the patient could follow along with her. Her notes were similarly organized, concise, and assessments were well-reasoned. She was able to interpret several common disease scripts. So you can even use the I as an interpreter, right? Disease script, diagnostic testing, same with primary care, she performed at an early manager level. So this preceptor is well-versed with the levels of within each one of these areas, each one of these characteristics. So this preceptor is identified this student as an early manager, was able to propose through plans for chronic disease management, for example, diabetes, hypertension. For more straightforward cases, she was able to manage on her own, and for more complex cases, she was able to provide solid recommendations. She is eager to learn, frequently reads up and reports on clinical questions we encountered. She responded well to feedback. So here's the plus, the improvement, and made appropriate corrective actions to improve her clinical skills. She should continue to expand her differential diagnosis skills, which should strengthen with more experience. Wow, every single one of those were covered. Boom. So if you had time, and we know you don't, you could go this route. All right, we have 4 more examples, and just letting you know that from now we've seen all like exemplars, right? These are exemplars. Now let's go through the last couple of ones where we look at the first try and we see how we might be able to improve. So the first try, student B possesses a superior knowledge, so there's medical knowledge based, superior knowledge base of physiology and basic science above that seen in most third-year students. This is not bad at all, right? Meaning that there's no improvement. It's not like there's a weakness. So obviously the preceptor is focusing on strengths. But if I were a residency program director, would I want to pick this student over the one that had the previous narrative? Like, there's nothing in there that makes me want to take a chance, because they're basically doing what they're supposed to be doing. You get that? So, and even if I were to look at, and so obviously they're focusing on medical knowledge, but even if I was focusing on Prime Plus, maybe interpreter, EPA, maybe diagnostic and screening tests, or 7, clinical questioning, right? And KSA, obviously just the K. There's no skills or attitudes involved. So if we were to improve this, how about this? Student B demonstrated an ability to apply his deep understanding of physiology and basic science. So here's an application of medical knowledge, right, to new clinical problems. This was demonstrated. Now here's the example. By his ability to formulate appropriate differential diagnoses and propose sensible steps to narrowing the diagnosis and developing a therapy plan. For one patient, now we're getting very specific. He discussed drug adverse effects that I had not considered in the differential. I mean, just put it out there. Sometimes students are just like, they see something that you don't, because you are so pressed. And you know, you're just going through a lot, and they have the time to reflect a bit more, right? They can step back and maybe say, you know, I remember Dr. So-and-so back in year 2 saying something about that, and then they can go home and look it up, because that's what they're focused on, is, you know, passing their shelf exams. And so they're going to be looking for these sort of things. Okay, so now we've expanded beyond medical knowledge to patient care and problem-based learning and improvement. Fantastic. Example 7, first try. Student M did a good job presenting complicated patients on rounds, not a bad thing. Able to synthesize large patient data, fantastic, and generate a good differential diagnosis and management plan. So again, this is one that is about the patient and medical knowledge, but really what this says is they did a good job. And so why not just label them with that, you know, identifier, good job. You know, you've gone beyond, so here's evidence, but we need that example to set them apart in their application to residency. So here's the revised version. Student M did a good job presenting complicated patient records on rounds, able to synthesize large patient data, and generated good differential diagnosis and management plan. Nothing changed, right? She was very engaged and proactive, for example. So now here's an example backing up that evidence, right? Doing orthostatics, honor patients to assess volume status, or doing ME to assess patients for underlying dementia. She also collected valuable patient data from doctors' offices, great help in assessing and managing patients. She had great rapport with patients and all team members caring for the patient. You cannot say enough about that personalization, about how a student interacts with patients and teams. And that's something that I see over and over again, is focusing on the rotation and not on the growth of the student as an upcoming resident, meaning able to integrate with a team and be seen as a valuable member, even though they are as low on the pecking order of being a part of a healthcare team. So they're always looking for improvement, and they're always looking for kind of that soft skills, that interpersonal communication. So this is what we've picked on: patient care, knowledge, professionalism, improvement, and the bigger context of systems-based practice. Let's see, got a couple more minutes. Here's example 8. One of our outpatient rotations during the OB-GYN clerkship, student L was noted to be helpful, punctual, very proactive in care areas. Her history taking skills improved. Ooh, it hurt. I mean, typical third year doing typical third year things, but there's no indication of what level they are performing at. And notice, it's also passive in nature. Student L was noted to be helpful. So there's no interaction between the preceptor and the student. I noted is a much more active, forceful statement than somehow somebody noted this person to be helpful and punctual. Or you could say, my, whatever, my office manager, my nurse, those sort of things, fantastic, right? So we focused on communication, and we can expand this by saying, on the outpatient segment of the rotation, student L was always on time by the end. She was reviewing patient charts, participating in the team huddle, asking good questions. And her downtime, she took initiative. She used apps, right, for guidelines and appropriate questions about their abilities and circumstances. And, she even asked help for taking sexual history, those skill improvement. After direct observation, quickly responded to feedback on how to improve. This is somebody I would want, because obviously they grew a lot in 4 weeks, right? So we have that patient care aspect still, but we have a lot of improvement and kind of the bigger picture, like tying back to guidelines and knowing that this is bigger than just somebody presenting in an office, right? Last example, and we're out of here because we're almost done. Student V is a good learner, was adept with the electronic health record, and worked well with clinical staff. Yay! Again, this doesn't tell me a lot if I'm interviewing. And so we could fill it out with examples. Fulfilled all duties in his 2 weeks in the HIV clinic. Now remember, they'll have in the MSPE what rotation this was, but it doesn't hurt for you to reemphasize that this is just not a core rotation. This is something that was a bit special, right? Documentation quickly improves, understood the requirements of this setting. 2nd week, he correctly entered some orders and prescriptions, talked about interactions, verified it with myself and the chief, and obtained informed consent. And I mean, just went on. That last one, he handled a family member's outburst over delayed pain treatment calmly and respectfully. I want that person on my team, not necessarily the first one. All right, so we talked about communication again, systems-based practice, and obviously patient care. So when you sit back and do it, you should be able to look at these narratives and say, would I want to hire that student as a resident if I was a director of a program? Just think about that while you're writing. And so to recap, because my dad was in the Air Force, you tell them what you're going to tell them, you tell them, and you tell them what you told them. So here's the end of it. An effective narrative evaluation. There's your first objective. Comments on performance is specific and written to the audience. And a narrative that provides useful information, uses a framework, and we talked about them, focuses on 1 to 3 areas of that framework, and includes examples. And if you do those things, I promise you, both the students and the program directors who read your words it'll just be much more robust, much more rich, and hopefully with better outcomes. So given that, I am done. Again, my name is Kevin Kalinowski. You can always reach us at com-evaluations@shsu.edu. You can Google my name and I'll show up with a goofy picture. But if you have just any general information or questions about evaluations, you can hit us there. And my coordinator of evaluations, if he can't answer it immediately, will send it to me. And if I can't answer it, I'll just get other people involved. So my job is to make you successful. And so if there's anything that I could have done differently or you need more of, please leave feedback and let me know. And I can, when we post this online, maybe there's an FAQ or this presentation that we can upload so you can kind of look back through the thought process on the frameworks and how to improve first tries to revise versions. And we can get it. We can make this a good process for everybody. So again, we cannot graduate students without you, and I cannot thank you enough as the hat of Director of Assessment and Evaluation and Accreditation. So thank you.
Thank you so much, Dr. Kalinowski. We do have a few minutes left, so if you have any questions, feel free to drop them in the chat, and I'd be happy to read them out for Dr. Kalinowski. Dr. Herman has mentioned he hasn't looked at them yet, but would you suggest the appendices from the original article worthwhile?
A lot of those appendices were, if you were to run this workshop, here's the activities that you would do. And so a lot of what they walk you through in the presentation, it's like a half-day workshop, is how to be a better narrative writer. And so you break up into small groups and you talk with your peers, and you might write something down and you review it and you say, what framework did I use, and all that sort of stuff. So the appendices are valuable in that they help you walk through that process of becoming a better narrative evaluator. Right. But I would say if you were just going to read those and think you walked away with everything they said, the article says it all. I mean, truly. And the appendices are good, especially if you want to go through those activities. And especially if you have somebody to do it with, it'd even be better. Yeah. Anything else?
Dr. Herman, thanks to you, Dr. Kalinowski.
Oh, fantastic. You're welcome.
If there are any other questions, feel free to drop them in the chat. If not, Dr. Kalinowski has left the email address here for us. Oh, I'll pull it back up.
Sorry.
No, that's okay. We will also be providing a follow-up email either this afternoon or tomorrow. In that, we will provide a link to our assessment, and I'll also drop that here in the chat. This assessment, we would like you to fill it out and provide any feedback for our program or for Dr. Kalinowski. Additionally, at the end of the assessment is your CME claim credit information. It will provide a link and a QR code that will redirect you to our joint provider to claim your CME, but we'll also include that in the email. So if you forget it here, don't worry and look for our follow-up email. Another thing to note is we will be moving our CME offerings. It will still be in a Zoom webinar format, but we will be introducing a Blackboard course organization for all of our faculty and preceptors. So all of the collection of CME presentations will be available, along with any information in regards to claiming your CME credit, your preceptor benefits, and more items like that from SHSU College of Osteopathic Medicine. So if there are no other questions, we thank you so much for joining us for this CME in November. And we are so thankful for Dr. Kevin Kalinowski for presenting. We hope you all have an amazing afternoon, and we'll see you next month in December. On December 8th, we'll do a presentation on coordinated care. So look out for more information on that. Thank you so much, and everyone have a great afternoon.